Everything presented today is our own opinions and views, and we do gratefully acknowledge funding from Convatec. So it's now exciting to see that there's now a third generation of catheters on the market. What's different is that there's a catheter with field clean technology, and it has integrated amphiphilic surfactants, or IAS molecules, embedded into the actual polymer surface of the catheter. So there's no coating, there's no need for manual lubrication, and there's no PVP. It's not messy either. The lubrication essentially is built in. And these molecule heads bind water to the surface, creating that lubricious layer needed for insertion. So at Queen's, what we wanted to do then was investigate the differences in the properties of all these different catheters and compare them against this new third generation field clean technology catheter in terms of their friction and their relationship with the urethra. So what we wanted to do at Queen's, and we published a method where we looked at a traditional coefficient of friction model and altered it at the actual counter surface that we test the catheter surface against was a seeded urethral epithelial model. So we made silicone molds and grew uroepithelial cells on these molds and tested the surface straight against these cells. We looked at 2 different time points that were very important. So we will talk about 0 minutes, that was to mimic our insertion, and 2 minutes withdrawal. So this graph was what we did to calculate the area of cells still remaining on the model after we had pulled these catheters across the urethral cells. So the first 2 bars and images highlighted here show our controls. Then next we looked at the IAS, so the field clean technology catheter, as you can see in red. And yes, they're definitely at the 0 time point, so where it was hydrated and immediately advanced across the cells, there was some damage. And then again, you can see damage at 2 minutes, which was actually increased. But where we start to see really interesting differences in this model is when we look at these hydrophilic coated PVP containing catheters. And you can see, yes, again, damage at 0 minutes, but where the differences are really starting to become significant is at 2 minutes. So there's a lot more cell damage or cells removed from the model that we think was potentially because of this dry out and stickiness happening to the coatings. But what about the cells that are still remaining left on these catheterization tracks? Are they happy? Is there any damage to them? What do they actually look like? So we decided to take lots of images and we conducted a blinded visual scoring of these cells in terms of their damage and morphology. All of these hydrophilic coated containing PVP catheters, they actually were ranked to have moderate damage across the board to the cells, whereas the IAS catheter, the field clean technology, actually had mild. So we looked at the actual urethral model itself, and we noted that for the hydrophilic coated catheters, the coating residues were actually coming off and remaining behind in this urethral model. It's really interesting to remember that actually each time that we've performed this, we've only done 1 essential catheterization, but you're thinking that patients generally do this multiple times a day, potentially for the rest of their lives. So we don't know, is this happening every time? Is this residue accumulating? And if so, is there any effect at all to this?
What Jane has described to you is an in vitro model where we have that single catheterization interaction between one side of the catheter and then a monolayer of cells. So what we've been trying to do then recently in Belfast is actually move that to be something much more representative of what happens within the human urethra. So here on the left-hand side, what we have is a porcine penis, so a pig's penis. What this allows us to do then is get this full 360 contact between the whole surface of our catheter and the urethral tissue. So on the right-hand side here, you can see that using Convatec's field clean technology, it actually reduces the force required to withdraw a catheter. And when it's compared to several of the PVP-coated technologies, you can see that there's a significant reduction in that force. So we believe that's because the PVP can begin to dry out while it's in situ within the urethra, and that can cause that adhesive sort of interaction that Jane has talked about already. Correlating with our in vitro model, when we actually added a dye to the rehydration fluids, we could first of all see the coatings of the different technologies. And then importantly, after that catheterization process, you can see here that on the PVP-based technologies, we can see quite clearly that there's partial delamination of the coatings and in some cases clumping of that PVP coating. So what we wanted to understand is what's the clinical significance of that? And if we actually opened up the penis and looked at the lumen of the urethra, we could actually see for all of the PVP-coated technologies, there was coating residue remaining within the lumen. Because if patients are using a catheter 4 to 6 times a day, we already know there's that increased risk of trauma just associated with intermittent catheterization. But our models have now also shown that there's this risk of residues being left behind by a coating-based technology. And the majority of these patients don't have that natural flushing effect that urine provides when it passes through a urethra. So essentially any debris within the urethra, such as these residues, may be allowed to accumulate, and what clinical consequence can that have? And then if we think specifically towards males, they don't just use the urethra to pass urine, it's obviously for reproduction as well. So is there any risk of actually the semen coming in contact with these residues as well? Because if any of you are involved with IVF, you may know PVP is commonly used to actually slow down sperm cells so that clinicians can detect live cells and use those for fertilization. But within the last 10 years, as you can see here, there's a building evidence base that's actually showing that PVP can be detrimental to sperm health. So what I don't want anyone to go away with here is thinking that these are definitely problems. What I'm saying is, in the literature, there's no actual evidence of people even looking at these residues. And we as a research group at Belfast are hoping over the next year, we can start to build more of an evidence base to find out, is this clinically significant or not? And we hope others within the field do the same.
I'm not going to put it to our panel to just see if there are any questions.
Yes, as I know from the past, most of the studies which have been done on friction and the force which is needed to retract the catheter. In my clinician everyday life, what patients complain about is the fact that some catheters are sticky and they feel that the urethra is sticky with the catheter. Do you think that with your model we may have more explanation about why they are feeling this sensation?
Yeah, so there's been obviously, well known, I should say, a lot of patients feel that tugging sensation, and Jane mentioned it before. And what we think our model is showing, particularly that force model, the Ex-Vivo, we can see that there is that increased force needed for particularly PVP-coated technologies, and we think that's showing that there is this adhesive force, that sort of glue-like force between the tissue and catheter. So we're hoping this is helping build that little bit of evidence base to see why that tugging sensation is felt with the PVP-coated catheter.
Just to know if you tested the withdrawal after 2 minutes, because I saw that you tested at 2 minutes. I think that not all the populations doing intermittent catheterization are able to do the intermittent catheterization by 2 minutes. Because, for instance, for poor dexterity in neurological patients, but also in people who complain pain. Mm-hmm. They can take even much longer than 2 minutes to do the intermittent catheterization. So I wonder to know if surely there is a relationship between time and a sticky phenomena. Do you know something more about that?
Yeah, so the reason why we took 2 minutes was essentially we looked at the literature and looked for an average time, but I completely agree. There are those who can take even up to 15 minutes potentially, and that will allow much more interaction with the actual catheter surface. So we have looked at further data, and we can see that it does allow coating-based technologies to dry out slightly more, but where we've tried to really focus is sort of looking at best case. So we've kept to that sort of 2 minute area, but as I would agree that the longer these are left in place, there is more risk of that dry out from happening, which will cause stickiness.
So in a way, you're showing the best case scenario. It could be worse.
Yes, it could potentially be worse, yes.
So I've been hurt for 36 years. I have a spinal injury. Later on in life, decided to try to have kids. And I'll just say that it was not an easy or enjoyable process, as maybe it could be. For me, sperm motility was a major contributor to that. I'm naturally predisposed to have a lower sperm motility because of my injury. And so, you know, it's interesting listening to the data. I will tell you, as a patient advocate, I speak regularly to new spinal injury patients. And always when I'm speaking with the young guys, the young men, and they hear, hey, I'm married, I have 4 kids, they perk up a little bit and they think, oh, wow, I can do this. Like, I can have a family. But I will say that the issue of sperm motility and catheterization with the PVP-coated catheters, that for me individually, would be a concern. And I think as a patient advocate, I'm all about patient choice. I want to be very clear on this. But what I think is most important is educated patient choice. So not showing any bias, but educating. And I think it's our duty and responsibility to, share whatever data we can to help minimize those negative effects of, potentially having a family one day.
So I want to talk to you about a clinical practice principles that we developed, and it's part of the Convatec Me education program. We wanted to have something that we could use in our practice, literally use in our exam room when we are educating patients, whether you be a physician who's educating, a nurse, or maybe not a nurse, someone else, a healthcare professional or not, who's initiating intermittent catheterization. And we really found there really isn't some stepwise as far as what you have to include when you do teach someone. We got together an international panel of experts who are in urology and continence care. And, we sat around through a Delphi method trying to figure out what do we want to do as far as what principles are important. We also wanted to validate what we developed, so we actually took it out of users who do intermittent catheterization. So there's 3 components to them. We start with pre-consultation. What does that individual, that clinician need to do to prepare to start teaching, educating that individual on intermittent catheterization? What is done with that patient consultation? And then what is the ongoing support? So let's start with pre-consultation. And this is basically the patient journey from when, whatever that may be, they know they have to catheterize themselves, or I don't know what happens in your practice, but at Penn Urology in Philadelphia, literally somebody comes out of an exam room and says, grabs someone and says, go in there and teach them how to do intermittent catheterization. What is needed? What does that clinician need as far as preparing that patient? What is happening when you actually are there with that patient teaching ongoing? But let's start with pre-consultation. And there's some components of this that we have as far as to help you with understanding how to prepare. And really, it's really what is that interaction between that patient and that healthcare provider? As far as education, product choice, and also we want to make sure that it's individualized. And I think this is really an important thing, and that's hard in practice. It's not like one size fits all, is it? You really need to individualize. We actually go through different considerations that you want to do, and that's the pre-consultation. Then we have the actual patient consultation when you're there with them. And we have some really neat things that we have developed to assist that patient from when they're in your exam room, when they're with you, when you're teaching, and ongoing with videos and that. And I want to go through a few of those. Basically, we developed a checklist. Now, I'm sure you recognize that we wanted 1 page, but we had like 5 pages in our head, right, to include every single thing that we want there. We wanted to have a checklist that was as succinct as possible, that had the key points, that you can sit with your patient in the exam room and you can literally have that checklist that you can check off. I went over this, yes, this, and maybe even have that checked off, print it out, and give it to that patient so that it's in their record, but also they take it home. Because what we've learned is that you're giving them a lot of information, but how much are they absorbing? What is developed as part of these principles is an actually personalized video, and this is brand agnostic. So this is actually a generic type of video that really they can see when they leave. And I really recommend that you utilize this because, again, they don't remember everything. If maybe that checklist helps, but they may forget. What did she say as far as how many times to catheterize? What did she say about how I put it in? That type of thing. So it goes over, preparing yourself, preparing your environment, preparing the product. How do they open it? How do they use it? Insertion and voiding, removal, and then disposal. So this is a patient-oriented video that really provides that additional information and augments what you have educated them in your office. So now let's go to ongoing support. Now, because we have so much material that we couldn't put in the base of these tools that we've developed, we decided to have an FAQ, so frequently asked questions. Now, we came up with 10 at the top, but then we have like 70 questions that they may have. And I think that this is really, really important as far as understanding, you know, what if this happens? What if was this? So that they know, yeah, that can happen and this is what you can do. This is more around Convatec as far as interactive video to navigate through risk factors for UTI, personalized video instructions with repeating what needs to be done. And then we also have a relaxation center and an education library that they can access. So I hope you're thinking this is a lot of material, isn't it? And it's really, really needed. You know, I really get a little upset when a patient comes in, I learned everything on YouTube. I have to tell you, how many, there's not a lot of accuracy on YouTube, okay? And it is of concern, is that's where they're getting their education. I mean, that may augment some of those YouTube videos, but it would be better if us as clinicians initiate that education and then they can go to a reliable source as far as learning more. The emotional well-being modules and workbook have been developed as an adjunct to this clinical practice guidelines, or really principles. But what the emotional well-being is to really try to work to build the confidence of these individuals catheterizing themselves, reduce their fears.
So I'm Sula, I'm a health psychologist and psychotherapist, and my specialism is in supporting patients with chronic illnesses. Psychology is not something that medical professionals really think about. It's something that just happens, and, you know, that's not my role. But what we know from the research in this area and in broader areas in long-term health conditions is that it has a massive impact on outcomes. It has a massive impact on adherence. It has a massive impact on pain. And in the context of intermittent catheterization, it can have a massive impact on the likelihood of complications, post-voiding retention and infection and injury. But also, more broadly speaking, how the person lives the rest of their life, right? Their mental health, their ability to engage in the life that they want to engage with, and how they see themselves as a person. So we wanted to quantify what are we really trying to help patients with here. On one hand, we're wanting to empower them to catheterize with confidence so that they feel capable and able to catheterize, so that they feel supported by their clinicians to do that in the best way possible to avoid complications and avoid injury. But on the other hand, we also wanted to address the mental health impact and the broader life impact, the emotional well-being impact. And we wanted them to feel good in themselves, right? We want them to have an intact self-esteem and it not to be negatively impacted by the fact that they're now a catheter user. We're very realistic on time, and we're very realistic on what your role is. You're a physician, you're not a psychologist, and we also know that lots of clinicians don't really like to open up something that they feel they might not be able to close down. So we wanted to create something that could remain in everyone's comfort zone, but still addresses things that are currently unmet in patient consultations commonly. So we distilled it down into this really simple framework, which is ask, validate, empower. And what this really boils down to is when you are able to ask your patient questions about broader well-being, but in specific relationship to catheterization, it automatically validates their experience and it helps them articulate things that they might not have been able to really understand that they were feeling or worrying about. You provide an opportunity for them to accept that, yes, that is having an impact on me and I do need to think about it. And that in itself is empowering. And that's where our patient program comes in, which is really, really exciting because it's, you know, completely self-management, but it's also very interactive. So it's a web program, it's got interactive videos, patients get prompted with particular questions, and then they'll have tailored responses based on what they've answered. And then there's workbooks that they can download, they can print off. We've got 10 modules that they're working through, and we start with just helping people reflect on what catheterization means to them as a human, not just the specifics of catheterization, but how it fits in their life and how they feel about it. And from there, we then go into the common fears and concerns and how that interacts with the pain that they might feel when they're catheterizing. And then our next 4 modules are really tailored to helping people integrate catheterization into their lives through to movement and then intimacy, which is the topic that every patient wants to have addressed, but no patient gets addressed. And then the next 3 modules are really about looking at that whole person, how they can work with negative thoughts and fears that commonly come up. All of this helps them build confidence in their change that they've gone through, having to now be catheter users. So at the very end, we get them to reflect on their goals that they created at the beginning, what they want to get out of this, and we use that opportunity for them to create goals going forward, and they can continue to use the strategies that they've used in the program so far. And what we're hoping all of this does is change all of those outcomes, right? Physical health outcomes as well as mental health outcomes. We want them to be able to adhere to catheterization. We don't want it to be painful. We want it to be comfortable. We don't want all the complications and backing off because of fears of UTIs. But we also want people to feel confident in themselves and accepting of this new normal for themselves in a way that doesn't feel like a compromise, but feels like a new version of themselves. So to finish, I'd just acknowledge my colleague Alicia Hughes, who's not here, and all the IC users that fed into this program and continue to, and of course, Convatec.
So I think in my practice, working in urogynecology, I often work with a different group of women when catheterizing. I have far more short-term patients, potentially, rather than long-term patients. But also, we have to think about variations across life course, changes in women needing during pregnancy, during menopause. And I think one of the things that these guidelines capture with the individualisation is not only about at those points, but with the ongoing support, the changes that may happen across their course. So utilising that and individualising it, I think really makes a difference for my patient population, but it also works for all the other populations. As with many other things, such as the intimacy, we often don't delve in further. Number one, because of time constraints. Number two, because of lack of knowledge. We don't have the knowledge, the training, the skills. And when you do ask a question, yes, for a lot of patients, it's important to validate it. But if we've not then had anything to offer them, there are limited access to services, not having anything to then offer them, all you can do is validate their experience, and you've not got anything to go from there. So I think knowing now that you have something to offer, I hope will help people to initiate the conversation, recognise the issue, but then know that there's a whole package that you can send them to.
As nurses, we are so best placed to support the person in therapy adherence, and especially due to emotional well-being. Adherence to therapy will be altered or will be a big problem. And so it's really an issue that we as nurses can take up and help the patient go through the different stages where he's going through.
You mentioned very important aspect, readiness to accept new knowledge. When my patients coming to rehab, it's usually within a few weeks or months after spinal cord injury. The first question, what they want? Will I able to walk? And you try to teach him, no, wait, walking probably not a priority. You have to learn how is your blood functioning. You have to learn how you poop on a daily basis. You have to dress yourself. And so many things in front of them immediately. And that's why education is a challenge in acute rehabilitation stage. And that's what is this guide is providing aspects, follow up. You have to give first educational session and remember that probably he or she will forget about this, and you can come back again and again and again and bring this knowledge to patients.
When I was 17, I was a hard-headed jock. I thought I knew everything, and I just remember my doctor saying, I'm going to have to put this straw in my penis to pee. And I was scared, if I'm just being honest with you. I was scared. I had a lot going on. I was relearning everything. But having a tool like this could have saved me the first 2 or 3 years of constantly being in the hospital on an ongoing basis because I was not compliant. It was just something that I wasn't willing to do. And so my body paid the consequence for that. And so having a great tool like this to provide emotional support, encouragement, real-life resources and examples of people that are helping to normalize this, I think is a huge step in the right direction.
So I'd like to just give a round of applause for our speakers, our panelists, and of course our audience. Thank you very much.